Here we go.
Okay. So everyone can see my screen, I hope. Awesome, awesome. Hello, everyone. Welcome to this workshop. I am really proud and happy to be here this evening, and together with the Farmington Hills Community Library, I would like to present this evening this workshop called Child Development, Screening, Diagnosis, and Services. I'm Dr. Tisa Johnson-Hooper. I am a practicing pediatrician at Henry Ford Health, and I've been there for over 20 years. I provide primary care for all children, but I have a particular interest and, quite frankly, a passion for providing primary care for children and youth with special healthcare needs. I'm also the medical director of the Henry Ford Health Center for Autism and Developmental Disabilities, and I'm a member of the diagnostic team. Let's see, I'm going to, bear with me, I need to move. Everyone from around, there we go. So this evening, I would like for you to understand the major developmental milestones. I would hope at the end of this talk, you can appreciate how primary care provides how primary care providers identify children who are at risk of developmental delay and understand the evaluation process available and available services, and then recognize the role and the value of your primary care provider on this journey. So we're going to start with a discussion with development. So development encompasses ongoing change. In the specific instance of child development, it is a process by which a child changes over time. It covers the whole period from birth to an individual becoming an adult. So there are 3 stages of child development. There's early child development, which spans from birth to 5 years. Next, there's middle childhood from 6 to 12 years. And lastly, the adolescent stage. So this stage actually has expanded over the years and now covers really from age 13 all the way to age 24. So the major developmental milestones are gross motor, fine motor, language, cognitive, and social emotional. Each stage of development is made up of these developmental milestones. Developmental milestones are a set of functional skills or age-specific tasks that most children can do at a specific age. So I acknowledge that children grow and develop at their own pace, but recognize the milestones are established to mark the average age most children accomplish specific tasks. So I mentioned those 5 developmental milestones. And there are age-specific age ranges that children acquire the skills within those domains. So we'll go over them specifically. The first is growth motor. And so that little peanut at the top left, he depicts an example of gross motor. So these are those skills that encompass the large muscle groups of the body, allowing us to roll, sit, fall, walk, go up and down stairs, hop, skip, and jump. So then there are those fine motor skills, the fine motor domain. So the little girl at the right is demonstrating beautifully her fine motor skills. So where the gross motor are the large muscle groups, the fine motor domain are those small muscle groups, like using the fingers to hold an object, transfer from one hand to the next, pincer grasp, placing those blocks up, using a pincer grasp, buttoning and zipping, using utensils, all fine motor skills. 2 little cuties at the bottom left, they're depicting your language domain. So language reflects the emergence of word use. So the cooing, babbling, the jargoning that babies do, using that first word, combining words into shorter, then lengthier complex sentences, telling stories. So language domain, it also encompasses how we understand words. So ability to begin to follow that single And then two-step instruction, answering open-ended questions or yes/no questions. The WH questions like who, what, when, where. Then there's the social emotional domain. Excuse me, and it's the ability to express your emotions effectively, follow rules and directions, playing with others, responding to other people's emotions, and forming those positive relationships. And so that precious little toddler at the top right is demonstrating beautifully her social emotional domain. Lastly, there's the cognitive domain, and that refers to the child's ability to think, learn, solve problems. So examples of cognitive milestones are responding to facial expression, learning the alphabet, your numbers, your shapes, colors, and solving problems. So now that we have defined development and understand the developmental domains, let's explore the medical journey from surveillance all the way to intervention by following the experience of a new patient of mine in my practice. So I'm going to tell you about this little kiddo. On this particular day, I have a new patient on my morning schedule. This is a 22-month-old toddler here for their first well-child visit in my practice. The family recently relocated from the South and was referred to my practice. So after being checked in, my medical assistant got her vitals and then placed my new patient and her parents in the exam room. So soon thereafter, I walked into the exam room, finding this little one sitting contently on her father's lap, holding a plush toy, a plush cause and effect toy. And there, this little one was pushing its buttons repeatedly while looking at its blinking colored lights. So I walked in, I greeted the family, introduced myself, and the parents introduced themselves and then introduced me to their daughter, who directed her gaze at my hanging name tag badge that I wore around my neck. And she stayed focused on it as I moved in front of her and sat down before she returned to her plush cause and effect toy, again, pushing the buttons. We'll talk about surveillance. So I like to think of surveillance as the behind the scenes activity of your provider, but it actually it's occurring right in front of your face, right in front of the parents. And you're just typically not aware of it. So surveillance is the process of recognizing children who may be at risk for developmental delays. So there are a few components of surveillance. And the first is what I was doing when I walked in the room, direct observation. So I'm observing the child caregiver interaction, as well as the child's interaction with me. This definitely relies on a great deal of clinical acumen or experience and knowledge of child development in order to develop an accurate impression. Next, there is eliciting parent or caregiver concerns. Simply me asking, like, do you have any concerns for Snudley? Or could you share your concerns about Snudley's growth, development, or behavior? The third component is identifying risks and protective factors. So this is done when your pediatrician asks you all those questions about your child, obtaining the birth history. So what was the mother's age or her health during pregnancy? Were there any prenatal exposures to like cigarettes, drugs, infection? What was, labor and delivery like? What's the family history of this child? Is there family history of like autism or a cognitive impairment, hearing loss, or behavioral health diagnoses in the family? I want to ask about the social history of the child. Like, who lives at home? What are the exposures in the house? How much screen time does the child get? What is their sleep, diet like? And is the child often read to? So it's a lot of questions around social history. So all of that information, along with the developmental history, it's maintained in your child's medical record. So lastly, surveillance includes sharing. It's the sharing of my opinion and findings with the caregiver, and if warranted, with other providers or other systems of care, whether that is a community mental health organization or if that is even through the schools or early on. So in short, surveillance encourages parents to ask questions and express their opinions. It increases satisfaction and provides information parents want and need. And it provides the opportunity to promote developmental skills. Back to my little peanut. So I had already engaged in surveillance as I walked into the room. And my clinical observation, I noticed that this child did not depict any joint attention. And that is a developmental skill that emerges around 9 months, that I typically look when I walk into a room, that the child, regardless of what they're doing, if they look at me, they then look back at their caregiver to say, do you see what I see? And then look back at me. So it's that shared attention. And I noticed that little peanut never did that when I walked in the room. There was no social referencing. So this peanut, I would have expected to have had some type of emergence of stranger anxiety. And I would have expected this the child to look at the caregiver, to almost look at the caregiver's facial expression, as to say, is this friend or foe? Should I be fearful or happy? What should I do? To reference the caregiver. And she did not do that. She maintained her gaze on her plush toy and then my name badge. There was really no eye contact with me or her caregiver throughout that assessment, and then really no communicative intent. So those are my observations that I had in just that short, brief time walking into the room. But next, I want to elicit, what are the parents' concerns? So I'll say, hey, share with me your concerns regarding Snuggley's growth, development, or behaviors. So this mother noted she was concerned with her child's talking. She said she had 3 words when she was 15 months, and she was no longer using those words. So throughout, that assessment, I then, looked at what are those risk and protective factors. And for this little peanut, her family history was, the risk factors was that her family history was positive for hearing loss in an older sibling, and father was recently deployed overseas. Now, protective factors, which are equally important to identify and to know, is that her prenatal history was unremarkable. There was no cigarette, drug, alcohol exposure, no bleeding or infection during pregnancy. She was a full-term infant, uncomplicated health history. She's read to daily, multiple times daily, by her extended supportive family and really limited screen use. So then, I then am able to share my own clinical observation, my concerns with this family. And I was concerned about her delayed language and very clear pointers of autism. So I provided insight to this family about what typical development, language, and social skills should look like at around 22 months of age. So screening. Screening is the use of a standardized, validated tool to identify areas in which a child's development or behavior differs from age norm. The American Academy of Pediatrics recommends that developmental and behavioral screening for all children during regular well visits at 9, 18, and 30 months. Specific screening for autism is called out and recommended at 18 and 24 months. We know that mental health and developmental screening across the pediatric lifespan, it is a best practice as endorsed and recommended by the American Academy of Pediatrics. It is important to remember that surveillance, what I talked about in the previous slide, is not screening, and it should not be thought to take the place of a validated screening tool. So think of surveillance as working together with those specific screening tools. Screening is important because it's not always obvious to the doctor, the child care provider, or even the parent that a child may have a developmental delay. And from my perspective, I'm an experienced clinician, been doing this for a little bit, and I only have a real small window, 15 minutes really, to make my observation. And no child is going to show you everything they can do in 15 minutes. So it is important to utilize a validated tool that gives an accurate, close to accurate assessment, snapshot of that child's development at that point in time. So it's incredibly helpful. So most screening tools are brief questionnaires that the caregiver can complete about their child. They usually can take about 5 or 10 minutes to complete. Developmental screening can be done, by a doctor, by a nurse, by the caregiver. It's done often in early childhood education centers and communities or school setting. And again, it's just that snapshot of the child. So, slide depicts an algorithm that was published in 2020, and it's a pediatric screening algorithm, and it's intended to serve as a model for universal system of screening for all children in the primary care setting. So the red row depicts the location of the screening. So screening occurs in the newborn period, specifically metabolic and hearing screening. The health supervision reflects screening to be done as an outpatient primary care setting. And then the green line depicts what is screened. So in the outpatient, we should screen for developmental disabilities, vision, and behavioral and emotional problems. The purple line really specifies what type of developmental disabilities are we screening for, from intellectual to learning disabilities, specific language disorders, autism, motor disorders, and then those high-risk conditions. I want to emphasize, though, that regular screening increases the opportunity for the child and family to benefit from early identification and intervention. My subsequent groups of slides, we're not going to go over in detail. I put them together mainly for if you were looking and wanting to reference a particular screening tool. I provided a list of screening tools, and the heading of what they're screening for. The citation at the bottom is a wonderful journal article that can give more detail. So I wanted the listener to have available to them the list of some very common developmental behavioral screeners. Remember, the screeners are or caregiver would complete these questionnaires, typically 5 to 10 minutes, and there are many out there. In my practice, we use the survey of well-being of young children. There are screeners for autism. These are two very common screeners that are out used. Most commonly, the MCHAT is what is used. There's a lot of psychosocial screeners, and I list those out for your review. Screeners for anxiety, depression, and suicide. Here are some common ones that are typically used in the primary care setting. So social drivers, or the social determinants of health, according to the World Health Organization, are conditions in which people are born, grow, live, work, and age that impact both their physical and their mental health. And examples of the social determinants of health include food insecurity, education, housing, literacy, social economics status, your access to healthcare, and discrimination based on race and ethnicity. And I included this because there are numerous studies that suggest the social determinants of health account anywhere from 30 to 55% of health outcome. That makes the case that the social determinants of health should be considered when providing health care to achieve better population health outcomes. As such, it is essential to screen for those social determinants of health, as they will influence a child's development and health outcome. So I listed here 3 common screeners that include questions around social determinants of health. So let's return to my patient that I spoke of. So I said earlier, the American Academy of Pediatrics recommends autism screening at 18 and 24 months. But autism-specific screeners can be used at any time that there is a parental or provider concern of autism. In this case, I use the Modified Checklist for Autism in Toddlers, or MCHAT, which is a validated tool for children 16 to 30 months. In my practice, the parents also will get at this age a SWIC. And we use the 18-month SWIC on this little kiddo because it's validated from 18 months up to 22 months. So it was an appropriate screener for this little peanut. And so it includes screening on the developmental milestones that I spoke about, along with a psychosocial developmental screener and a family screener and a social emotional screener. It's a very comprehensive screener. So for this kiddo, based on their screeners, she's screened at high risk for autism, and her SWIC was positive on the POSI, which is another social emotional or screener for autism. Okay. So based on the surveillance and the screener results, what I ultimately did for this little peanut, and reviewed this with the family, we went ahead and referred her to audiology for her hearing, referred her to our speech and language for speech assessment and evaluation, and then to our multidisciplinary autism clinic, CAD, for an autism evaluation, along with a referral to early on for early intervention services. So that referral was done. So let's talk about this evaluation process. So remember, we've talked about surveillance, we've talked about the screening, and I think it's important to know that brief screening test that is used, whether it was the MCHAT or the SWIC, they're a screening tool, and it doesn't provide a diagnosis. It tells you this child is at risk, and that there are some developmental delays that are identified, but it is not diagnostic. And so it just means that it indicates that the child is right to go on for a specialist to take a closer look. So if the screening tool identifies an area of concern, a formal developmental evaluation may be needed. And this formal evaluation, taking a deeper look at the child's development, is done typically by a trained specialist. So depending on the nature of the concern, the child may be seen by a myriad of specialists that are listed there. And it can be evaluated by a developmental pediatrician, a child psychologist, a speech pathologist, a neurologist, occupational, physical therapist, geneticist, just a myriad. So that would be depending on what the concern was. The specialist may, observe the child, give further questionnaires or tools, do their independent assessment, including having parents fill out additional questionnaires. That's the medical evaluation. But just like with my patient, there are other areas that you would want that child to be evaluated. And so I referred my patient also to early on. And so for her age, from those children that are birth to 3 who are at risk or who have a developmental delay, they can tap into early on for early intervention services as well. For the older age, 3 and above, they would tap into the school systems for that evaluation and special education services. Depending on the child's insurance, those children who are Medicaid eligible, the referral could also be through their community mental health to tap into services. So there are many different silos that a child can get to their eligibility or their diagnosis and services, and that can be done concurrently. So for this kiddo, as I said, I sent her to audiology, speech and language for her speech evaluation, autism multidisciplinary evaluation, and early on. I'll talk specifically about autism evaluation, as that's probably where I get most of my questions from families in the community, wanting to know what what does an autism evaluation consist of? And at my Center for Autism and Developmental Disabilities, we have a multidisciplinary approach, and it is often described as the best practice, meaning there's multiple clinicians that are looking at that child at one moment in time. I have to acknowledge and recognize this may not always be feasible, and an evaluation may occur over multiple days and sometimes over weeks for provider availability. My team consists of a neuropsychologist, speech pathologist, pediatrics, and psychiatry. We do evaluate the child at one moment in time. It's a full day assessment. And regardless if it's a single day or over multiple days, a comprehensive evaluation must, at a minimum, include that parent interview, an observational assessment, and some type of standardized validated tool for that observation assessment, a mechanism to evaluate that child's current level of functioning, adaptive skills, and really it needs to be done by experienced clinicians who have particular experience in social communication, behavioral, and play. Let's see, I'm sorry, my screen froze. There we go. So this kiddo actually went through that entire process, and from our multidisciplinary evaluation, the child was diagnosed with an autism spectrum disorder, a severity level 3, a developmental language disorder, also a restricted eating disorder, and pica, meaning mouthed and would eat non-food objects regularly. So research shows that early intervention treatment services can improve a child's development. And early intervention services can help children from birth to 3, as I spoke of, and it'll help them learn those very important skills, those children that are 3 and older, if they're identified with developmental delay or a disability. Special education services through schools may then be provided. And so definitely services will include a variety of options depending on the child's need, such as specific therapy, like occupational, physical, or speech therapy, social work services. So those are services that can be tapped in through the school. Medical for this child with autism services that were recommended were applied behavior analysis, speech therapy, occupational therapy. Behavioral health is a medically based service that could be employed. And then I spoke just briefly about the community mental health, depending on insurance eligibility. I have kids in my practice that if they're Medicaid eligible, we'll refer them to community mental health, where they will get those myriad of services along with the medically based services as well. So it really, from my perspective, working with families can be quite a lot to try to navigate those 3 different silos of care, if you will. For this particular child, I am this child's primary care provider. So once she went through the diagnostic evaluation and early on for their eligibility, came back to me so that I can help coordinate her care in the context. What you'll see here is called the medical home primary care. And what I put that there not to confuse you with a medical home, meaning this child needed a particular physical location for their care, but it's medical home is an approach to healthcare that really all children are deserving of, but particularly children with special healthcare need greatly benefit from this approach to healthcare. And that's care that is family-centered, continuous. It's comprehensive care, because as we had talked about, this child's getting care from many different silos. It's accessible, coordinated, culturally competent, and compassionate. So my role as a provider, providing that medical home approach, it is my role to sit and partner with the family to look at all the types of care this kiddo is getting and helping the family coordinate it, helping them access services, prioritize services. And in the context of doing primary care, as I would for any child, making sure the child has her vaccinations and anticipatory guidance with, eating, sleeping, elimination, all that primary care stuff. But there's just a lot more layers to it when a child has a special health care need. And so for this child was getting her primary care with me, but also getting ABA services, OT, and speech and language services, in addition to her early on services. I put this slide here just to illustrate that the journey we just talked about really detailed kind of that top line, that plan A, that straight from one point to the next. But I want to definitely raise your attention and shine a light on the fact that that plan B is really what the journey looks like for many, many, many children, fraught with a lot of barriers and delays and circuitous routes to ultimately get to the point where there is diagnosis. And unfortunately, those delays really are because of a lot of the social drivers of health that I spoke about. We know that provider bias influences the clinical judgment. So that surveillance that I spoke to you about, that really is influenced by provider observation, it really, if we all bring bias to everything, and so depending on that provider's bias, may overlook certain behaviors and attribute it to one thing or another and not raise those red flags. Definitely the evidence in literature has demonstrated that there are great disparities in screening rates for children. If we're not screening, we're not identifying. And we see cohorts of children, Black and brown children, screened and diagnosed much later age. And there's definitely disparities in the positive screening rates. And this can be due to parental bias. It could be influenced by literacy, cultural interpretation of behavior. There's many reasons why maybe parents may not have that concern. So if I ask a question like, what are your concerns for Snowdley's behavior and growth and development? A parent may not bring forth any concerns based on their own bias or interpretation. And then lastly, there are disparities in the type and the frequency of referrals that are given to children in order to get that accurate diagnosis and services. So I just want to highlight that so that families are aware when you have your little one, and if you may have a concern, and trying to empower families to speak up, but more importantly, empowering families to take the time to learn a little bit more about typical development so they know what to expect and what to look for. And that's one of the reasons why I gave a list of so many of those screeners that you can, they're accessible. Pull them up on the web. I included some resources there that if you have a little one or know a little one or caring for a little one, so you can know what to look for at each developmental age. But this slide, again, is just, I always want to give as much information and resources to parents. I think knowledge is power. And these are some wonderful resources for families who are interested in child development from the CDC's monitoring and screening site. Please do jump on and look through them for resources. And I believe, that is my last slide. I want to thank you for the time and your attention today for this talk.